Hello and welcome to this video on the alterations of musculoskeletal function. In this video, we are going to talk about disorders of skeletal muscle, starting with secondary muscular dysfunction, and we'll discuss contractures first. So this will be a lack of full passive range of motion in a joint because of muscle or soft tissue limitations. Now we can categorize this as being physiologic or pathologic. When we talk about physiologic contractures, these are temporary, in which the muscle fiber is shortening without an action potential, and it's caused by a failure of the calcium pump, even with available ATP. So we see this in people that have McArdle disease, which we're going to talk about in the coming slides, or malignant hyperthermia, which we've discussed in previous videos. Just to give you a quick preview of what McArdle disease is, it's when an individual lacks myophosphorylase, which is an enzyme that is needed to break down glycogen in our skeletal muscle to turn it into, or not turn it into, but to break bonds in order to release the glucose that's stored in the glycogen. And then our muscles, therefore, can't access the glucose, and this leads to a lack of available ATP. Now, with our pathologic contractors, these are permanent, and they are when the muscle is shortening due to muscle spasm or a weakness. So it's typically caused by a neuromuscular disorder. It could be a stroke, ALS, muscular dystrophy, or cerebral palsy, and occurs even with normal ATP levels and action potentials. So common causes of this would be when someone is immobilized for a prolonged period of time. Maybe we've got muscle imbalances going on, or scar tissue formation in something like a burn injury. And we tend to see that the lower extremities are more commonly affected than the upper limbs. Another topic under secondary muscular dysfunction is stress-induced muscle tension. I feel like I've definitely had this before. It is going to involve symptoms like neck stiffness, back pain, and headaches. And it's associated with chronic anxiety, and our abnormalities that it will involve are found in the CNS, reticular activating system, and our autonomic nervous system. So when a muscle contracts, the muscle spindle is going to be activated. Remember that this is our sensory organ, you can think of it as, and it's going to trigger a gamma feedback loop. So it sends a signal through our A1 afferent fibers to the brain, which in turn are going to increase activity of our reticular activating system, and this leads to a increase in gamma efferent firing, causing further muscle contraction and tension. Now, our autonomic nervous system may also contribute by increasing sympathetic activity and blood flow to our muscles that then only enhances the muscle tension. So the best treatment options for this is going to include progressive relaxation, yoga, meditation, and biofeedback that are all aiming at reducing stress and lowering muscle tension. Next, we have fibromyalgia, and this is going to be a chronic, widespread, diffuse joint and muscle pain, fatigue, and tender points type of condition. And some of the common symptoms with this are pretty complex, but are going to include cognitive issues, so memory problems. We also have a hypersensitivity to touch or stimuli. It can also involve psychiatric disorders like anxiety and depression, and we have an absence of inflammation. So I actually was having some musculoskeletal issues, and my physician thought I might have this. So one of the things he wanted me to do was to go and get a blood test so that we can see if there were any markers for inflammation. And if there wasn't, then it would point to fibromyalgia. And there's also fatigue and non-restorative sleep as a symptom. So we do see that fibromyalgia is more common in women and affects about 2 to 3% of the general population, with the peak age between 30 and 50 years old. And there have been studies of genetic factors that have implicated alterations in genes affecting serotonin, catecholamines, and dopamine. And right now, fibromyalgia is classified as a central sensitization disorder involving nociplastic pain. So pain from altered nociception without tissue damage. So let's talk a bit more about clinical manifestations. The prominent symptom is diffuse chronic pain and a profound fatigue. And typically the pain that they're feeling is starting in the neck and the shoulders. Some other symptoms might be headaches, irritable bowel syndrome, and cold sensitivity. We can also have some key features like the hyperanalgesia, like we said, them being really sensitive to touch, allodynia, which means they if they have a stimulus that is normally not painful, they perceive it as being painful. And also temporal summation, meaning that if they're having a pain, it intensifies, especially with repeated stimulation, even if that stimulus doesn't change. So if you're just kind of tapping with the same force over and over again in the same area. The diagnosis would be using some of those clinical findings such as axial pain, left and right sided pain, upper and lower segment pain, and a symptom severity index score. We can also use something called a widespread pain index. And the SSI score would include symptoms like fatigue, waking unrefreshed, and cognitive difficulty. Now, to evaluate and treat this, we want to rule out other musculoskeletal conditions, kind of like my physician did with the blood test. But if we do point to fibromyalgia, the best treatment is going to be multimodal. So we can combine things like exercise, sleep improvement, stress reduction, maybe taking some medications like pregabalin, our CNS active drugs, or vitamin D. We can do some therapies like CBT, acupuncture, neuromodulation, and hyperbaric oxygen therapy, and just educating the patient and making those lifestyle changes so that they can manage this long term. Next, we have chronic fatigue syndrome, which is also called myalgic encephalomyelitis. And this is quite a debilitating condition. It is going to be characterized by profound, persistent, unexplained fatigue that's worsened by physical or mental activity. It's also going to involve cognitive impairment, musculoskeletal pain, unrefreshing sleep, which is also known as non-restorative sleep. It's when you wake up kind of feeling tired and groggy, like you haven't slept at all, even if you got a full night's rest. We can also have some impaired neurologic energy production, some autonomic symptoms like a sore throat, headache, and tender lymph nodes, and immune impairments. Now, the cause of this is unknown, and to diagnose it, we use it as a process of exclusion. And we are starting to classify this, kind of like fibromyalgia, as a central sensitization disorder rather than more of a musculoskeletal disorder. What this means is that we have an amplified central nervous system processing of pain and sensory signals. So in this type of disorder, the brain and spinal cord become overly sensitive, meaning that our normal stimuli can cause exaggerated pain, and even that non-painful stimuli can be perceived as painful. And our pathophysiology is still unclear at the moment. Some other signs of this syndrome is going to be visual changes, chills, night sweats, GI issues, and chest and jaw pain. To diagnose this, it's based on exclusion and CDC criteria, meaning that we have this persistent unexplained fatigue, reducing activity levels, and we have to have at least 4 symptoms of lasting 6 or more months. That would be memory issues, pain, post-exertional malaise, and sleep problems. For the treatment, it's more symptom-based management. So again, doing things like improving your sleep, managing your pain and mood, having supportive care like counseling and nutrition, and alternative therapies like acupuncture or massage, doing things to really reduce your stress and anxiety. And unfortunately, there is no cure. Now, within chronic fatigue syndrome, we can start to have disuse atrophy, and this is when we have a reduction in the normal size of muscle fibers as a result of prolonged inactivity. Basically, we have an accelerated degradation of our myofibril proteins, and that occurs due to things like aging, like sarcopenia, inactivity, like when we have bed rest, or we have to wear a cast due to trauma, or if you're an astronaut going up in space and not having that gravity or exercising while you're up there. We can also have some local nerve damage, so having some type of neurological injury like spinal cord damage or poliomyelitis, which usually isn't the case. And we can also have this due to chronic illnesses like cancer, AIDS, congestive heart failure, COPD, renal failure, or burns. Now, as far as the pathophysiology, it's triggered by oxidative stress or lack of, but in addition to a lack of activity. And this leads to us having decreased protein synthesis and an increase in protein breakdown. So I kind of bring this as an analogy to osteoporosis, where we are losing bone faster than we are able to build it. So same thing here, we break down the protein faster than we're able to create it. And the effects can be seen within 5 days of inactivity, and muscle strength starts to decline by 3% per day on bed rest, which is pretty alarming. So for prevention, we want to have good nutrition, do isometric muscle contractions, and passive lengthening exercises like stretching. And we want to focus on restoration. So reintroducing mechanical load through resistance training, stretching, or electrical stimulation, and doing more of those isometric contractions. Now let's talk about muscle membrane abnormalities. We have this umbrella term called skeletal muscle channelopathies. These are inherited diseases that are caused by alterations in our skeletal muscle sodium and calcium ion channels, which can lead to things like myotonia, which is a delayed muscle relaxation, or periodic paralysis, which is episodic muscle weakness or paralysis. So let's start with our myotonia first. This is going to be caused by abnormal ion flow, especially when we're talking about chloride and sodium, and it disrupts membrane stability. So we have delayed relaxation after that voluntary muscle contraction, which causes disabling muscle stiffness or weakness or both. So common areas where we would see this is in hand grip and eye closure. And for treatment, we want to use drugs that would reduce excitability. And pictured on the right-hand side here, we have a syndrome known as Anderson syndrome, and this is a rare genetic disorder that's characterized by episodes of muscle weakness and paralysis. We're going to talk about periodic paralysis in just a moment, but the abnormalities are affecting more of the electrical system of the heart that can cause abnormal heart rhythms or arrhythmias and a variety of distinctive facial and skeletal features. Now, when it comes to the periodic paralysis, we will see that we have a severe depolarization, making the muscle unable to be fired again. So this is caused by an autosomal dominant mutation that affects the sodium, potassium, and calcium channels. And as a result, it's causing paralysis or myotonia. Now we have two different types. We have hypokalemic, and actually before I discuss those two types, let's also look at this image over here where we have myotonia, and we can see that it is on this end where we have delayed relaxation after our contraction, whereas our periodic paralysis, we're on the other end. So this is really where that Anderson syndrome is sitting. And so to touch on the hypokalemic PP or periodic paralysis, this is triggered by certain conditions like thyrotoxicosis, which is a condition in which we're having excessive secretion of our thyroid hormones, T3 and T4. This causes us to increase our sodium potassium ATPase activity that then pushes the potassium into our cells and leads to low blood potassium. So that's where that hypokalemia comes from. And that is then going to cause us to have muscle weakness and or paralysis. And this condition can also be due to other potassium imbalances. So the best way to treat this is to use potassium supplements, our potassium sparing diuretics, and high salt diets. Now, closer to the middle over here, we have our hyperkalemic PP, and this is triggered by us having increased potassium. And also when we rest after exercise, because when we exercise, potassium shifts out of our cells, and during rest, it moves back in. And this is called a rebound effect. We can also have it triggered if we have a carb-rich meal. This then will cause a surge in our insulin, which drives potassium into our cells, and our sodium channels are then overly active or are improperly closing so that they are more open than usual, and then we will have that persistent depolarization take place. In order to treat this type, we can use light exercise, be mindful of our carbohydrate meals, and also use intravenous calcium gluconate, which will help stabilize our muscle cell membrane. Now, there's also another disease I didn't list here. It's called CCD, or central core disease. This is also going to involve a mutation in the RYR1 gene that would affect our calcium release from the sarcoplasmic reticulum. Now let's discuss metabolic muscle diseases. So this can come about through endocrine disorders. Our systemic effects of hormonal imbalance will overshadow our muscular symptoms. So the incident in which I mentioned back here when we were talking about hypokalemia, periodic paralysis, and how it is going to be triggered by thyrotoxicosis, and that could cause proximal muscle weakness, eye muscle paresis. And if we think about the opposite end of this, such as hypothyroidism, that can lead to reduced muscle mass and strength with sluggish and weak muscles. So just in that glimpse of our thyroid gland and thyroid hormone, we can see how it can really affect our musculoskeletal system, because our thyroid hormone really has a role in regulating muscle protein synthesis and electrolyte balance. And they typically improve with proper hormone treatment if we're suffering from any of those disorders. So let's talk about some of these diseases of energy metabolism, starting with our glycogen storage disease type 5, and this is also known as McArdle disease that I mentioned earlier. This is a genetic disorder where we are going to have an inability to metabolize glycogen because we lack glycogen phosphorylase, or PYGM. And this, again, was the enzyme that we need in order to break down glycogen to utilize glucose. So we know that our muscle requires glycogen and lipids for energy. So when we don't have these fuels, we can't metabolize properly due to that enzyme deficiency. So individuals are going to experience fatigue and muscle pain and cramps, especially at the start of exercise here in the McArdle disease. Now, this disease is autosomal recessive, and they may experience a second wind where energy is going to start to improve after that initial fatigue because our body starts to shift into utilizing free fatty acids. So if we were to continue, though, the intense exertion that we would have from exercise can cause muscle breakdown, and basically we would have rhabdomyolysis, which we discussed earlier, and that could cause us to have myoglobinuria, that Coca-Cola urine. Now, another condition is known as acid maltase deficiency, also known as Pompe disease. And this is when the body needs energy and this large molecule of glycogen is broken down into glucose. And in order to do that, we are going to need an enzyme known as alpha glucosidase, or GAA enzyme. And so in this disease, we have a mutation of the GAA gene that encodes for the instructions to make this enzyme. Now, luckily, this is a rare autosomal recessive disorder, but what can happen is without this enzyme being present, the glycogen builds up in the lysosomes. And I'll point to it here since this is where we're talking about the disease. And if this is happening in the infant, we are likely to see symptoms like hypotonia, respiratory weakness, dysreflexia, cardiomegaly, enlarged tongue, and hepatomegaly. In the adult form, it's typically more mild, and we just see tissue enlargement, and that's due to the excessive glycogen storage. And in order to diagnose this, we want to get that GAA activity tested or do a muscle biopsy. Now, another disease of energy metabolism is adenosine monophosphate deaminase deficiency, which is also known as myoadenylate deaminase deficiency. Lots of long names for these diseases, but it really describes what's going on. So this is going to be a common autosomal recessive enzyme deficiency type of disorder that affects our skeletal muscles. And it's because of this enzyme that is playing a role in producing energy once again. So the deficiency of this myoadenylate deaminase is going to impair our ability to generate phosphocreatine and ATP during exercise, which is going to result in poor energy production for sustained activity. So our symptoms would include things like a post-exercise muscle cramping or pain, and being easily fatigable. And in severe cases, it can also progress into rhabdomyolysis, whereas some patients are going to have no symptoms at all. And to manage this, there is no definitive treatment, but we want to avoid rigorous exercise in order to manage the symptoms. Now, the last disease in this category is going to be our lipid deficiencies. And these are rare, but we know that muscle cells are going to use free fatty acids for energy, which are oxidized in our mitochondria. This process requires carnitine and the enzyme carnitine palmityl transferase, or CPT, in order to transport that long chain fatty acid to the mitochondria. So if we have a CPT deficiency, meaning we don't have that enzyme present, then we're going to have symptoms of mild muscle issues with potential for renal failure, liver failure, nervous system damage, seizures, coma, and sudden death. And some of these are due to rhabdomyolysis taking place. So in order to treat this, we can use riboflavin, medium chain triglycerides, oral carnitine, prednisone, and propranolol in order to manage the symptoms. The last topic we're going to discuss are inflammatory muscle diseases known as myositis, and also some myopathies in the coming slides. So infections that are viral, bacterial, or parasitic can lead to myositis, which is inflammation of our skeletal muscles. Things like tuberculosis and sarcoidosis are going to be chronic inflammatory changes and granulomata that are going to be found in our muscle as well as in our affected tissues. Then we have trichinosis that is caused by ingesting infected meat like pigs or wildlife, and our symptoms would include gastrointestinal distress, muscle pain and stiffness, and a rash or fever developing, and we could treat it with corticosteroids and anti-parasitic agents. We could have toxoplasmosis, which leads to polymyositis, and other infections like a bacterial infection caused by Staphylococcus aureus and other parasitic infections that could cause muscle pain and inflammation. And many of us have also been infected with a virus such as the influenza virus that has caused things like muscle pain and elevated creatine kinase. Now, when it comes to idiopathic inflammatory myopathies, we'll see that they too are characterized by inflammation of skeletal muscle and would include what we call polymyelitis and dermatomyositis, and we'll soon talk about inclusion body myositis. And these are all autoimmune disorders. So when we talk about our polymyositis, or PM, and our dermatomyositis, or DM, we're going to see muscle weakness in areas of the hip, thighs, upper arms, and neck, and it may involve difficulty swallowing or breathing. And our DM is going to include a distinctive purple rash on the eyelids, where we can see over here. We could also see this type of discoloration or rash on the elbows, knees, or the knuckles, and sometimes even abnormal calcium deposits that form hard lumps found underneath the skin, and this is called calcinosis. Now, when it comes to our sporadic inclusion body myositis, we'll also have muscle weakness, but this time it's more in the wrists, fingers, and the front of the thighs, and we may have difficulty walking and grasping items. For medical treatment, we can include things like corticosteroids and anti-inflammatories, and we want to incorporate lifestyle changes such as including exercise, rest, good nutrition, and reducing stress. Next, we have toxic myopathies, and these can develop due to a couple different things, but the most common cause is going to be alcohol abuse. We can also have triggers like repeated intramuscular injections that have been associated with changes in the muscle fibers. It tends to cause a local necrosis of the muscle fiber and elevated CK concentration. And with time, the segments of the muscles, especially in the areas like the deltoid and the quadriceps, get converted into fibrotic bands. So when we talk about a myopathy, let me also define this. It's going to refer to a primary muscle disorder that affects the muscle strength, tone, and the bulk. So, no matter the trigger, we are going to have some characteristics to this, such as muscle weakness, which is usually symmetrical and proximal, though sometimes, like in myotonic dystrophy, we're going to see the distal muscles affected. We also will see pain and swelling after large consumptions of alcohol, especially. We are also going to see a decrease in muscle tone. The tendon reflexes are going to be reduced and atrophy may be present. Fatigue will be another symptom. It's typically mild and associated with the muscle weakness that we have. In certain cases, we'll have hypertrophy of the muscle, and in others, we will see an absence of fasciculations and sensory changes. Now, let's say that alcohol is the reason for the myopathy. Then what we want to do as far as treatment is to abstain from alcohol, improve our nutrition, and manage coexisting conditions like peripheral neuropathy. And for other toxicities such as intramuscular injections, we want to avoid those injections, especially in areas like the deltoid and the quadriceps. Now let's go ahead and answer this question here. Which disease is characterized by an increase in uric acid levels? If your answer is A, that is correct. Now, I know this was in a previous video as far as the information on this, but hopefully you remembered and got this correct.